Today's lecture topic is going to be on consolidation, ground glass, and atelectasis. The goals and objectives of this lecture are first to be able to reliably differentiate between consolidation, ground glass opacity, and atelectasis. So how can we do that on CT and on chest X-ray? Then we want to be able to have a differential diagnosis. So we'll look at the most common causes for these particular entities and how we should kind of group them. And then finally, to look at some helpful signs and clues to help us narrow that differential, and also use some clinical information to come to a most likely diagnosis. Let's first talk about consolidation. Consolidation is a process in which the alveoli are becoming filled with something. That something could be exudate, it could be pus, it could be water, it could be blood, it could be tumor, it could be some sort of inflammatory cell. And when the alveoli are completely filled, the lung will appear solid. So the definition of consolidation is a process that replaces alveolar air, rendering the lung solid. And that's what we see on the right. We can see that there's an area of lung opacity that is rendering the lung solid. On CT, we'll note that this opacity will obscure vascular and bronchial markings. So notice that we can see normal vascular markings in other areas of the lung. When we look in this area of the lung, we can note that the vascular markings are completely obscured. We don't see any vascular markings. We also can see the outlines of the bronchial walls. If the bronchi are aerated, that is that they're not impacted with debris, we could actually make out air bronchograms, and that's these branching structures in here. So we could actually see that there's some air bronchograms. This is what we call an air bronchogram. If those bronchi are mucus-filled, we can call them mucus bronchograms. So sometimes we see air bronchograms within the consolidation, and sometimes we see mucus bronchograms. Not uncommonly, consolidation can be mass-forming, so we can look for secondary clues of mass-forming processes by looking at the fissures. In this case, there isn't any mass-forming process here, but if there was mass-forming consolidation, what we could see is bulging of the fissures. So that's this area down in here. The fissure was being pushed away from the consolidation. We can see that that consolidation is mass-forming. So sometimes consolidations can be mass-forming. Ground glass opacities, on the other hand, represent partial filling of the air spaces. So either there's some process that's only partially filling the alveolar air spaces, or there's interstitial thickening that's too small to resolve by CT. So what does that mean? That means that there is a process in the interstitium. That interstitium is thickened, and because the interstitium is so small, we can't resolve all those little small lines, so the lung ends up looking kind of hazy, ground glass-like. Conversely, we could also see ground glass opacity when the lung parenchyma is normal. And what do I mean by that? I mean when we have an overperfusion of lung parenchyma. So sometimes we could see that in people that have chronic PE, a lot of the lung is not being perfused, so other portions of the lung become hyperperfused and therefore appear denser than they should, representing ground glass opacity. In addition, we could also see ground glass opacity as the result of incomplete atelectasis, or incomplete airless lung. The lung is partially air-filled, partially atelectatic, and therefore will appear abnormally dense. When we see this on CT, what we'll see is just a generalized area of hazy increased lung attenuation. In distinction to consolidation, we'll note that the areas of increased lung opacity will not obscure or distort underlying bronchovascular markings. So here we could see that this whole area in here all represents ground glass opacity. Within the ground glass opacity, we can make out airways, and we could also make out vessels. So we note that the opacity is not obscuring underlying bronchovascular anatomy. In addition, compared to consolidation, ground glass opacity almost will never have mass effect. It's never going to push things away from it. It's incomplete filling typically. With the incomplete filling, there's not going to be any mass effect there. So let's talk about atelectasis now. So what is atelectasis? Atelectasis means that there's reduced inflation of all or a part of the lung. Part of the lung could either be a segment or subsegment, in which we will say that there's subsegmental atelectasis. It could be a lobe, in which case we'd say that there's lobar atelectasis, or it could be the entire lung, in which we'd say that the entire lung is atelectatic. Because there's atelectasis, there's obviously going to be volume loss. You're removing air from the lung. When you remove the air from the lungs, it's going to create a void, like a vacuum, and as a result, there's going to be volume loss. So we can look for features of volume loss, such as displacement of the fissures, narrowing of the ribs, crowding of the bronchovascular markings. In addition, because atelectasis just represents airless lung, the lung parenchyma itself is actually totally normal. And when you take air out of the lung parenchyma is going to behave like any other organ. It's going to uniformly enhance. So if you give contrast in someone that has atelectatic lung, the atelectasis will uniformly enhance. And that's what we're seeing here. So here we can see that the entirety of the left lower lobe is collapsed. So we see that the entirety of the left lower lobe is collapsed. You see that there's vessels running through it. So the vessels running through it, we can see over here. And compared to the other side, the vessels are all crowded, and that's because there's volume loss. In addition, when we actually look at the lung parenchyma, when we look at the lung parenchyma in this area, we can see that the lung parenchyma is hyper-enhancing. So hyper-enhancing, and the way you know it's hyper-enhancing is you compare it to muscle. So if we look at the lung in here, and then compare it to the muscle out here, we can see that the lung is much brighter than muscle. In fact, there was a paper that did look at this, and what they found was that a Hounsfield unit of around 90 Hounsfield units was a good differentiator to separate out atelectasis, which is normal enhancing lung parenchyma, from, say, pneumonia, right? We don't expect pneumonia to enhance. All pneumonia will represent is filling of alveolar spaces with debris and mucus and pus, and that's not going to enhance. So one way that we can potentially differentiate atelectasis from pneumonia is by looking at what it does on a contrast-enhanced study. Obviously, you would have to have contrast on board to use this rule. And here's the paper for your reference. Okay, so let's compare and contrast each of these entities. So when we look at consolidation, ground glass, and atelectasis, so what is the cause? So what is the cause? So consolidation is basically filling of alveoli. You're filling up the alveoli with something, and the lung here is always abnormal. There's something that's replacing alveolar spaces. The alveoli are being entirely filled with another process. Ground glass opacity, on the other hand, can represent a couple things. It can represent partial filling of alveoli, so not complete filling. It can also represent interstitial thickening. And in fact, when you take a look at lungs that have been biopsied or explanted, the majority of ground glass opacity that we see on CT is actually interstitial thickening, not airspace disease. In addition, the ground glass opacity could actually represent normal lung, and the normal lung meaning either overperfused lung or incompletely atelectatic lung. And we often see this kind of hazy ground glass opacity at the lung bases when someone is getting a CAT scan, they're laying down, the lung is kind of becoming compressed posteriorly, and it has this ground glass appearance. So consolidation, the lung is always abnormal. Ground glass opacity, the lung, is typically abnormal, but it could also be a normal process as well. Atelectasis, on the other hand, basically means that the lung is airless, but the lung parenchyma is normal. So we're actually looking at normal lung parenchyma. So what is the appearance? So again, the appearance for consolidation is going to be solid, right? It's going to be solid. It's going to obscure underlying bronchovascular anatomy, and there's the possibility of mass effect. Remember, consolidation can push fissures away from it. Ground glass opacity, on the other hand, does not appear solid. It appears kind of hazy, right? It's this kind of hazy appearance of the lung parenchyma, like you're looking through scratch glass or ground glass. And this hazy appearance will not obscure underlying bronchovascular markings. And again, there's going to be no mass effect here. Lastly, atelectasis. The appearance of atelectasis, and this is a topic of a different discussion. We'll have a talk regarding the different types of atelectasis, the appearance of lobar atelectasis. But atelectasis, like we said, can appear solid. If the lung is entirely atelectatic, it can appear linear if there's an area of subsegmental atelectasis, or it can appear hazy if it's incompletely atelectatic, or almost a ground glass appearance, like we had mentioned at the lung bases when people are lying down to get their CTs and that lung is becoming somewhat compressed. You often will see volume loss associated with it, and one of the key things to remember here, and I really use this clue a lot, is on contrast-enhanced studies, atelectasis will uniformly enhance. It appears very homogeneous, and that's because the lung is normal. It's going to enhance normally. It's an organ that if you take the air out, it's going to look like a solid organ. It's going to look like the liver. It's going to enhance, and it enhances much brighter than muscle. Okay, so let's talk about consolidation now. So one of the easiest ways I think about consolidation is, again, it's something that's replacing the alveolar air spaces. So what are the things that can do that? So the big things that can do that, the big five here, are going to be the things that you'd expect. So blood, pus, water, inflammatory cells, as well as tumor. These are the five things you should always think about when you think about consolidation. There's something replacing the air sacs, air spaces in the lung, rendering them solid, and it's blood, pus, water, inflammatory cells, and tumor. When we talk about consolidation, the most important thing to start with consolidation is to figure out if it's acute or chronic. The majority of the time, the vast majority of the time, consolidation is going to be acute. Okay, but you have to first decide, looking at patient history, is this an acute process or some sort of subacute or chronic process? You could use prior studies, or you could actually use the patient's chart to see how the patient is clinically presenting. The other thing to remember here too is that when consolidation is present, often ground glass is also present. And that makes sense, right? Because consolidation represents areas of lung that are entirely filled up with something. Ground glass a lot of times represents incomplete filling. So obviously if you have an area that's completely filled, it wouldn't be uncommon for other areas of the lung or lung next to this area of consolidation to be somewhat incompletely filled. It's not totally affected yet. And therefore, it's not uncommon to have ground glass opacity present when consolidation is present. Let's talk about the etiologies. So for acute consolidation, the big ones here that you want to think about are pneumonia, aspiration, diffuse alveolar damage, and infarct. Okay? The most common that we're going to see is going to be pneumonia and aspiration. Pneumonia and aspiration represent the vast majority of consolidation. It's one of the first things that you should be thinking about when you see consolidation in the lung parenchyma. It's not uncommon, though, to actually have other causes in the acute setting, such as pulmonary edema and alveolar hemorrhage. These less commonly cause consolidation, though in the appropriate clinical setting, so the patient's volume overloaded, they have a big heart, they're actively hemoptysizing, you could certainly think that just water and blood alone can completely fill up alveolar spaces and result in consolidation in the lung. And we'll talk about some specific appearances that will make you more favor edema and alveolar hemorrhage as opposed to pneumonia. You should also have a differential for chronic consolidation. You need to have a firm differential for chronic consolidation. So there are inflammatory causes of this. So the two big inflammatory causes that I want you guys to think about here when you see chronic consolidation is organizing pneumonia and chronic eosinophilic pneumonia. When you say organizing pneumonia as your differential as a first-year resident or even as a second-year resident, the next thing that should kind of spill off your tongue is chronic eosinophilic pneumonia. They share lots of imaging features. Because they share lots of imaging features, they should be on your differential diagnosis when one comes up. You could also see some vasculitides, as well as an entity known as lipoid pneumonia. These are people that aspirate oils, and it can cause a chronic low attenuation consolidation, which we'll talk a little bit about. The thing to really worry about, though, with chronic consolidation are two types of tumors. So not all cancers produce consolidation. The big two tumors that you have to know about are adenocarcinoma. So these are pulmonary adenocarcinomas and pulmonary lymphoma. Both pulmonary adenocarcinoma and lymphoma can produce chronic consolidations in the lung that can be easily mistaken for a pneumonia. And this is one of the main reasons why we recommend follow-ups for people that have consolidations on either chest x-ray or CT to make sure that they resolve. If they don't resolve, one of the things that you have to always consider is that you're looking at an unusual pattern of tumor caused by adenocarcinoma or lymphoma. And then lastly, you could also have some infections that can do this. So infections that may not respond to conventional therapies. If the patient is being placed on therapy for suspected pneumonia, they're febrile, they have a consolidation, they're going to be put on your typical therapies for either community-acquired or hospital-acquired pneumonia. But these therapies obviously won't cover mycobacterial infections, fungal infections, particularly endemic fungal infections, so like histoplasmosis, blasto, cocci. Or conversely, they do have a bacterial pneumonia, but the bacterial pneumonia is resistant or it wasn't fully treated, in which case the consolidation may not go away. And And then lastly, there are some congenital abnormalities of the lung that can produce consolidation. We're not going to get into this today. One of the big ones here is a sequestration.